Hello, everyone. I'd like to first take a minute to thank the FORCE meeting organizers for the opportunity to talk to you today about what's new in screening for colorectal cancer. My name is Bryson Katona. I'm a gastroenterologist at the University of Pennsylvania, where I serve as the director of the gastrointestinal cancer genetics program. Here are my disclosures. The only ones of which are pertinent are that I did participate in clinical trials for epigenomics, Guardant and Freenome, and I will briefly mention these products that are in development for colorectal cancer screening. So today, in the next half an hour, we have a lot to cover about screening for colorectal cancer. We're going to talk about the epidemiology of colorectal cancer first, then talk about risk factors, followed by methods for colorectal cancer screening, and then really try to talk a little bit about colorectal cancer screening effectiveness. But first, let's talk about the epidemiology of colorectal cancer. And before we get started, let's first make sure everybody's on the same page and at least just talk a little bit about what the colon is. So the colon, as you can see in this picture here, is essentially a 4 to 5 foot long part of the intestines and is oftentimes referred to as the large intestine. And thinking about the whole digestive tract, it starts at the esophagus, then the stomach, then the small intestine, and then the colon is the very last part of the digestive tract. The colon has multiple functions, the main functions of which are that it helps your body reabsorb water from your stool, and it also serves as a reservoir where stool is held such that you can evacuate stool at more defined points throughout the course of the day. Now, when we think about colorectal cancer is actually a fairly common cancer. It's actually the third most common cause of new cancer in both men and women, and also the third most common cause of cancer-related death in both men and women. And if you think about what your lifetime risk of developing colorectal cancer is, we typically say that risk is around 5% or so over the course of your lifetime. Colorectal cancer incidence and mortality has been decreasing over time. And what you can see here is that the top two lines on this graph are colorectal cancer incidence, which you can see over the last couple of decades have been decreasing. And you can also see the bottom two lines, which are colorectal cancer mortality, which have also been decreasing over the last several decades. Now, much of these decreases that you're seeing are actually due to the fact that we're using colon cancer screening to both reduce the incidence as well as the mortality from colorectal cancer. Now, one concerning area, though, is actually in young people. This is the one group where colorectal cancer is actually increasing, and this is individuals between ages 20 to 49. And this is primarily driven by an increase in rectal cancer. And it's thought that this proportion of rectal cancers that are found in young individuals will only continue to increase over time. So certainly a concerning trend, and we don't 100% understand why this trend is taking place. Now, in colorectal cancer, there are disparities that exist in both incidence and mortality. And of these two graphs here, you can see on the left, you have colorectal cancer incidence, and on the right, you have mortality. And what you can appreciate from these two graphs are that men have a higher incidence and a higher rate of mortality from colorectal cancer compared to women. And there are also differences in race and ethnicity, with non-Hispanic Blacks having greater risk of colorectal cancer incidence and mortality compared to other races and ethnicities. However, if colorectal cancer is found early, people do very well. And so if you look at the graph on the right here, what you can see is that if colorectal cancer is caught at a local stage, 5-year survival after detecting colorectal cancer is nearly 90%, which is really phenomenal. However, if you look at distant disease or metastatic disease, what you can see is that 5-year survival is less than 20%. And so I think this goes to show you that if colorectal cancer is detected and treated at an early stage, people do much better in the long run. So next, let's talk a little bit about some risk factors for colorectal cancer. And when we think about risk factors, we can first start with behavioral risk factors that affect colorectal cancer risk. So there are many things that are associated with an increased risk. So alcohol consumption, and heavier alcohol consumption is associated with a higher risk compared to more moderate alcohol consumption. Obesity. Red meat consumption and processed meat consumption are also associated with increased risk, and then smoking as well. And when you look at these risks, so when you see a relative risk of 1.2, what that means is that the risk is increased about 20%. And so while one of these factors may not increase the risk all that much, if you have multiple of these different factors that are all increasing the risk by 20%, it can lead to a remarkable increase in colorectal cancer risk. We know there are factors that decrease risk as well. So regular physical activity and eating a diet healthy and that has a lot of dairy are both going to reduce your risk. And things like increased physical activity doesn't just help decrease colorectal cancer risk, it also likely decreases risk of many, many other cancers as well. Now, besides behavioral and environmental factors, there's also thought to be a pretty substantial portion of colon cancers that are due to familial or genetic risk. So we think that about probably 3/4 of colorectal cancers are sporadic, but up to 1/4 of colorectal cancers are actually due to either some form of familial risk or a hereditary cancer risk syndrome. And while we thought that hereditary cancer risk syndromes only represented about 2 to 3% of all colorectal cancers, what we've now realized is that hereditary syndromes actually do represent a larger piece of this pie, with Lynch syndrome really being the most common hereditary cause of colorectal cancer, followed by polyposis syndromes. Now, how does family risk factor into things? And so if you have a family member who has an adenoma or a precancerous polyp, or better yet, a first-degree relative with a colon cancer, such as a sibling or a parent, that really plays a major role in increasing your own colorectal cancer risk and can actually double your own colorectal cancer risk. If you have a relative who has a colon cancer diagnosed prior to age 45, that increases your risk even further. And if you have more than one relative with colorectal cancer, that increases your risk even further. And so similar to many other cancers, the number of individuals who are affected, as well as the age at which they are affected, certainly portends a higher risk for a patient. And there are also many syndromes that I alluded to earlier, including Lynch syndrome. Lynch syndrome, there are 5 different genes that can be associated with Lynch syndrome, and you can see the colorectal cancer risks on the top left of this slide. Some of these genes are associated with a colorectal cancer risk over 50% over the course of a lifetime, which is just incredibly high. There's also a condition called familial adenomatous polyposis, where individuals will form between hundreds to thousands of polyps throughout their colon. In the classic form, this is essentially associated with 100% lifetime risk of colorectal cancer if preventative surgery is not performed. There are many other rarer syndromes that are also associated with increased colorectal cancer risk, including MUTYH-associated polyposis, Poyt-Jaeger syndrome, juvenile polyposis syndrome, Cowden syndrome, and Lee-Fraumeni syndrome. All right, there are also moderate risk genes that increase colorectal cancer risk, including the APC I1307K variant. This is a gene that's found in increased frequency in individuals with Ashkenazi Jewish ancestry, as well as variants in CHEK2, which is a common mutation that is found in about up to 1 to 2% of individuals and confers an increased breast cancer risk. However, there are many genes where there has been no colorectal cancer risk that has been definitively shown. So for carriers of BRCA1 and BRCA2, ATM and PALB2, and several other genes, at this point, we don't have great data showing that these individuals have increased colorectal cancer risk. So next, let's move on to talk about methods of colorectal cancer screening. And really, before we go into the methods of screening, I want to kind of get on the soapbox and talk a little bit about the phrase colorectal cancer screening. So I really do like colorectal cancer screening, but I don't think that it's the appropriate terminology, because really in the ideal world, when we're doing screening, we shouldn't be looking for cancers. What we should be looking for is polyps, which are essentially precancers that can then be removed to prevent cancers. But that being said, colorectal cancer screening, that terminology is undoubtedly here to stay. So let's think about colorectal cancer screening rates across the United States. And what you can see here is that there is a large difference in rates of colorectal cancer screening, with states in gray having the highest rates of screening and states in dark green having the lowest rates of screening. And I think the lowest one on here, I think, is Wyoming, which is about 58% uptake of colorectal cancer screening. But that being said, even the states with the highest rates, the rates of colorectal cancer screening are still only in the 70% range. And so there are still many individuals who are eligible for colorectal cancer screening who are not undergoing screening. Now, for an average risk population, when should you start and stop colorectal cancer screening? Well, back in 2017, it was thought that individuals between age 50 to 75 should always undergo colorectal cancer screening. Between 76 and 85, it can be considered based on personal factors such as individuals' health, and then it should never really be done after age 85. Now, in 2018, the American Cancer Society actually came out with a very groundbreaking proposal to start colorectal cancer screening at age 45. And fortunately, the United Services Preventative Services Task Force did issue new draft recommendations in 2020, really recommending that colorectal cancer screening be started at age 45. And so now the current recommendations for average risk individuals are that they should start at age 45 and screening should be done up through age 75. Between 76 and 85, it can be personalized based on patient preferences and other potential medical comorbidities, and it should not be done after age 85. Now, how do you do colorectal cancer screening in someone who is at average risk? Well, there are several different methods that can be used. The first methods are stool-based methods. And so this can include an occult blood test or a fecal immunochemical test or a FIT test. This is essentially where a bowel movement part of the stool is sampled and sent off for analysis. And these particular tests need to be done every year if they're going to be used for colorectal cancer screening. There's another stool test called a stool DNA FIT test, which is sold under the brand name of Cologuard. This also uses a stool sample to do the screening. However, if normal, this can be done actually every 3 years instead of every 1 year. The other type of studies that can be done are radiologic studies, and this really refers to a CT colonography, which is essentially a CT or a CAT scan that's done of the entire colon after a bowel prep, basically looking for any polyps or other abnormalities within the lumen of the colon. If normal, this can be done every 5 years in average risk individuals. And then the final category of tests that we have are the endoscopic tests, such as flexible sigmoidoscopy, which is where the first half of the colon is examined, and that can be done every 5 years if that's chosen, or a colonoscopy, which examines the entire colon, and if normal, that can be done every 10 years. So really, there are a wide variety of different tests that can be used for colorectal cancer screening in average risk individuals. Now, in individuals who are at higher risk, really in these individuals, colonoscopy is the only recommended method, and the other tests like CT colonography and stool-based colorectal cancer screening tests are not recommended in these higher risk syndromes. In Lynch syndrome, for example, individuals with either an MLH1, MSH2, or EpCAM mutation are recommended to start colonoscopy around age 20 to 25 and to repeat this every 1 to 2 years. Whereas individuals with a MSH2 or a PMS2 mutation can start colonoscopy a little bit later, between age 30 to 35, and repeat every 1 to 3 years. There are several other syndromes, which I had mentioned earlier in the talk on the bottom of this slide, where more frequent colonoscopy recommendations are also made as well. Now, I did mention some of these moderate risk genes, and there are several of these genes that are found very frequently on genetic testing panels. And so questions about colon cancer screening come up all the time for these particular carriers. So there is a little bit of uncertainty out there about how to do colonoscopy, and we collaborated with some colleagues at Memorial Sloan Kettering and Dana-Farber up in Boston to really try to publish some guidelines about how individuals should think about colon cancer screening who carry one of these particular variants. And really, if we think that for individuals who carry the APC I1307K variant or a CHEK2 variant, really colonoscopy should start at age 40 and be repeated every 5 years. For patients who carry a single copy of the MUTYH gene, really those colonoscopy recommendations should be based on family history and personal history, and you should not use the genetic result to do more frequent screening. Now, how about for the genes that are not associated with increased colorectal cancer risk? And I get asked all the time about colonoscopy recommendations for BRCA1, BRCA2, ATM, and PALB2 carriers. And really, for these individuals, screening should be based on personal and family history and should not be based on the genetic mutation itself. There have been several smaller studies out there that have tried to show that especially BRCA1 and 2 carriers are associated with increased colorectal cancer risk. At this point, though, I don't think the strength of the evidence is enough to recommend that these individuals undergo more frequent colon cancer screening. And we recently had published some of these thoughts in the Journal of the National Cancer Institute several years ago. Now, what's new in the field of colorectal cancer screening? So there has been a lot of exciting research in the field, and so I'll mention 3 different areas. One is blood-based colorectal cancer screening tests. The next one I'll talk about is capsule colonoscopy, and then finally we'll finish with artificial intelligence in colonoscopy. So first, let's briefly mention the blood-based tests for colorectal cancer screening. So I think that as I showed earlier, at least a quarter, if not more, of individuals who are eligible for colorectal cancer screening don't undergo screening. And I think that if we had a blood test that could be used for colorectal cancer screening, that would certainly increase adherence, because this particular blood test could be done, potentially when you're getting your yearly cholesterol or your other labs checked. Now, there's one test that's on the market now. This is the EpiProColon blood test, and this is manufactured by a company called Epidemiology. This test is commercially available. However, unfortunately, it didn't meet the strict sensitivity and specificity criteria that's needed for essentially broad approval for colorectal cancer screening for the average risk population. Although I know Epidemiology is continuing to optimize this test with hopes to be able to utilize it for average risk individuals in the future. There are also 2 other recent studies, the PREEMPT CRC study run by a company called Freenome, which just wrapped up recruitment earlier this year, and then a large study of the LUNAR-2 platform by a company called Guardant, which is still recruiting and probably will recruit through the end of this year. And both these assays developed by Freenome and Guardant are really aimed at, again, developing a blood-based test that could be used for colorectal cancer screening. And so I think it's very exciting to see all of these industry partners doing research in this area, and I'm really hopeful that one of these tests will be able to be utilized for colorectal cancer screening in average risk individuals in the near future. There's also something called a capsule colonoscopy. This is another new technique, where basically what happens is that there's a pill, which you can see up here on the screen. It's not a small pill; it's a large pill. But this particular pill actually has a camera and a flash on it. And what happens is that after doing a bowel prep, a patient can swallow this pill, and this pill can actually get into the colon. And as it tumbles through the colon, it can take pictures throughout the colon. Now, as you can see on the bottom right there are many pictures of the colon. So in panel A, you can see a very superficial blood vessel. In panel E, you can see a very small polyp. In panel F, you can see a bigger polyp. And in panel C, you can see something that looks concerning for a colon cancer. And so this particular capsule colonoscopy is not formally recommended for colon cancer screening yet, although I know it's being actively studied, and this potentially could be a method that is utilized in the future. And lastly, I just want to talk a little bit about artificial intelligence in colonoscopy. And so there's been a lot of advances in this field. And you may be wondering, how does artificial intelligence during a colonoscopy work? Well, what happens is that when the gastroenterologist is doing the procedure, this artificial intelligence is constantly scanning the pictures that are seen to look for any polyps. And when it does find a polyp, what it can do is it can real-time put a small square around that polyp so that the polyp is brought to the attention of the gastroenterologist. And you can see a potential example of how that would work here. On the left, you see a small little polyp. If artificial intelligence was being used, on the right is what the gastroenterologist would see. So for a polyp like this, you'd think, well, that polyp's pretty obvious, and you may not need a green square to potentially see that polyp. However, polyps can be much more subtle. And so if you look at these two particular pictures, if you look at the picture on the left, it's very difficult to see that there are actually two polyps on the wall of the colon there. And then these two polyps are then outlined by the green squares on the right. So it's really exciting because we know that identifying polyps and removing polyps leads to a reduction in long-term colon cancer risk. And so if you look at the research that's been done in artificial intelligence in colonoscopy, what you can see over the last couple of decades here is that the number of manuscripts and papers that are out there that address artificial intelligence in colonoscopy is going up dramatically. So I know this is being tested in many centers across the United States. We'll certainly have to see how research pans out and whether or not this will be something that's utilized standardly for all gastroenterologists who are doing colonoscopies. And so for the last part of the talk, I want to talk a little bit about colorectal cancer screening effectiveness. And first, I want to go back to an old study, almost a decade old by now, which is just a really fantastic study showing how effective colonoscopy is at preventing colorectal cancer. This was a large study from the Nurses' Health Study that followed close to 90,000 patients over the course of about 2 decades. And they found that of this cohort, about 1,800 individuals developed colorectal cancer and close to 500 individuals died from colorectal cancer. And what you can see on the table on the bottom is that flexible sigmoidoscopy itself reduced risk of death from colorectal cancer by about 40%. However, it only reduced death from colorectal cancer due to cancers at the very end of the colon, because again, the flexible sigmoidoscopy does not look through the entire colon. Whereas you see for colonoscopy, it reduced the death from colorectal cancer by approximately 70%, including reductions in death from both cancers from the beginning of the colon as well as cancers from the end of the colon. And so this is an old study, but I think it just really illustrates nicely how when colonoscopy is performed, it significantly reduces the risk of dying from colorectal cancer. Now, not all colonoscopies are equivalent. And I think another area that's becoming increasingly researched and increasingly brought to the forefront is indicators of a high-quality colonoscopy and a high-quality endoscopist. And so this was a really groundbreaking study. Again, it's a little bit of an older study, but continues to really impact the field, showing that differences in adenoma detection rate make a big difference in how many colorectal cancers develop after a colonoscopy. So the adenoma detection rate, or the ADR, is really equal to the percentage of average risk colonoscopies where an adenoma is found. And so each gastroenterologist should have their own adenoma detection rate. So I know mine, and every gastroenterologist at this point really should know their own adenoma detection rate. And what was shown is that the higher the adenoma detection rate, the lower the risk of an interval colon cancer developing, meaning a colon cancer that develops after an initial colonoscopy is performed. And if you look at the table in the top right, if you look at the individuals in quintile 1 who had the worst adenoma detection rates, between 7 to 19%, and compare those to the individuals who had the highest adenoma detection rate, or quintile 5, between 33 and 52%, what you can see is that for quintile 5, the chance of a subsequent colon cancer after a colonoscopy was essentially reduced in half. Thus showing that the more adenomas you detect, the lower the subsequent risk of colon cancer. And so really there's a threshold set that adenoma detection rate for all endoscopists really should be 25% or higher at this point. And it's totally okay to ask your gastroenterologist what their adenoma detection rate is, because he or she should certainly know. Another indicator of a high quality exam is actually the withdrawal time. And so when we do a colonoscopy, what is done is the scope is advanced as expeditiously as possible to the cecum, or the beginning of the colon. And then the colon is essentially assessed slowly as the scope is withdrawn. And so the time it takes to withdraw the scope is something called the withdrawal time. And there was this great study that was published several years ago that looked at individuals who had a shorter withdrawal time actually had higher rates of subsequent interval colon cancers that develop. And so what you can see is that if the withdrawal time is less than 6 minutes, the risk of developing colon cancer after that colonoscopy is more than 2 times the risk of individuals where the withdrawal time is greater than 6 minutes. And so what this basically means is that the more time you spend looking, the more things you will find, and ultimately the lower the long-term colon cancer risk. And so again, for withdrawal time, really this should be greater than 6 minutes for any screening colonoscopy. So today, hopefully, I provided a good overview of what's new in screening for colorectal cancer, focusing on some epidemiology, risk factors, methods for colorectal cancer screening, and some markers of colorectal cancer effectiveness. And I just want to leave you with a few take-home points. First is that colorectal cancer screening really is effective at preventing death from colorectal cancer. And in the average risk patients, there are multiple different methods that can be used for doing colorectal cancer screening. And for average risk patients, I think the best method really is the one that gets done. And so, whether it be stool tests or whether it be, CT colonographies or colonoscopy, I think it's just important for average risk patients that one of these tests is done. For high risk patients, though, colonoscopy really is the preferred modality. Third, I want to say that every colonoscopy is not the same, and that colonoscopy quality metrics are very important and are really coming to the forefront in the gastroenterology world. And then lastly, we really do need more research in this field. We need to develop better blood-based colorectal cancer screening tests. We need to find out whether or not we can utilize artificial intelligence to further enhance the benefits of colonoscopy. So certainly plenty of areas for future research. So thank you again for your time and attention. I hope this talk was helpful to you, and I hope you enjoy the rest of the FORCE meeting. Thank you very much.